department knee arthroplasty recently has increased because of improvement in techniques and technology, and also with the high volume center doing this surgery. But there are review of literature regarding a long-term deterrence effect on the joint line and outcome. It could be because of the abnormal joint line restoration with the conventional techniques. So, and even in the Presiti et al., he has come to the conclusion that early failures of UKA are because of most commonly due to the joint line restoration. So the aim of the study was to compare the joint line restoration between the robotic assisted UKR and conventional UKR. We hypothesized that the robotic assisted UKR has the better anatomical restoration of joint line compared to the conventional technique. We have randomized the 100 patients into two groups, with group A undergoing the robotic assisted UKA and group B going a conventional techniques, ideally for the anteromedial osteoarthritis between March 2017 to 2022. Group A has received a fixed bearing implant, whereas the group B has used the conventional mobile bearing design. All the patients were assessed clinically and radiologically with full standing X-rays and scanograms, and limb alignment and radiological assessment was done by the two fellows trained using a Weber's method. Both their groups were demographically comparable in terms of their demography. So coming to the measurement, we have used the ImageJ application to calculate the Weber's method. So Weber's angle is a calculation of an angle formed by the distalmost line on the femoral condyle and a line drawn tangentially to the lateral cortex. So clinically, the 2 millimeter landmark was suggested because on the radiograph we are not able to see the 2 mm of the thickness of the cartilage. So whenever the post surgery, the component is, if it is within the 2 mm, it is considered as the restoration of the anatomical joint line. So these are the paper which is suggesting that the distribution of cartilage thickness is 2 mm. So the Weber's method has suggested to use the 2 mm of the landmark. So coming to the result, comparing between the two groups, the distalization of component was higher in case of conventional group as compared to the robotic groups. That in case that 64% of patients undergoing robotic UKR have achieved a component placement within 2 mm. That is, the average is 1.6 mm plus or minus 0.49. Whereas in group of conventional group, the component placement was 2.47 plus or minus 0.5. And it was like observed by the two different fellows who were not the part of the study, and they were blinded for the study. So this is the post-operative joint line measurement. And this here we can see the component placement. We can tracking of the femoral component over the tibia. This is gap balancing, which is the pre-operatively. We can see the lax joint on 0 to 120 degree, and this is post-operatively after the balancing. Coming to the discussion part, the various studies have been suggested. By Roberto Negran, he has assessed the comparative analysis of joint line between the robotic versus conventional. He has concluded that the robotic technique has got a better joint line restoration as compared to conventional. Similarly, the cadaveric study was done by the Magli et al., and he has found that the component placement and the soft tissue alignment is better than in robotic as compared to the conventional techniques. And also the Zhang et al., he has done the meta-analysis, and he has came to the conclusion that the robotic assisted UKR are better in comparison to the conventional techniques. Limitation of the study, this is like sample size was smaller, and better measurement of technique is CT scan, but we have done with the X-ray technique. Long-term follow-up is essential to analyze the difference in functional outcome and aseptic loosening and survival. Conclusion that the handheld semi-autonomous robotic system can produce a predictability and high accurate results. The meticulous planning and attention of ligament balancing is better with robotic assisted UKA. The code need to be followed for a longer duration to validate the longevity and survivorship. This is now age of technology. Now we are like going from what we were initially, and now in the age of technology, we need to like move on with these recent technologies. Thank you.